want to open it up with just a couple of comments, and then I'm going to not talk long because I really want this illustrious panel to speak to you and you to speak to them. I think most of you, when you were invited to attend this symposium, probably when you first heard about the National Interoperability Collaborative, said, well, that's an impossible dream, and came to this meeting because you were curious about who was dumb enough to buy into this notion and think it's possible. Well, nobody's told us we can't do it, so we're just going to go ahead and do it, right? And I'm reminded of my English teacher in college who, when I wrote a paper, it was a very difficult assignment, and he kind of patted me on the head and said, Paul, just remember that it's much, much more noble, or much more better to fail at something noble than to succeed at something trivial. But we're not going to fail because this is an important thing for the country, and so we're going to move forward with it, but not without an understanding of the challenges. I think part of the complexity that we're dealing with in a national interoperability collaborative and initiative like this is that there are multiple dimensions that all interact with each other. There are three that I think we have to constantly keep in mind and are instructive. One is that in addition to the 6 domains that we're addressing with this interoperability, we also have another dimension of the jurisdictional content. We have federal, state, regional, county, city, towns to deal with, and as all of you know, that dimension of how do you organize and operate has its own concerns. You know, Chris Christopherson wrote a song back in the 70s that everybody has to have somebody to look down on. And, you know, there are certain federal bureaucrats that believe all wisdom lies on the banks of the Potomac and distrust state and local officials. There are state bureaucrats who are either jealous of or suspicious of local agencies at the county or city level because they're all doing this innovative stuff and the state can't do that because of the bureaucracy and laws. And in many states, and I think some of this is true in California, I know this from my background in living here and dealing with cities and counties, there are some cities and counties that have a lack of trust in the state. And that's a reality that we have to deal with. So building that trust relationship across those jurisdictional boundaries is one dimension of this problem that we have to address. The second dimension, of course, is the variation in the domains themselves. These 6 domains we glibly talk about each have their own culture, each have, in many cases, their own vocabulary. The meaning of words changes as you go from domain to domain. Just think about what's the meaning of the word case as you go from public safety to public health to juvenile probation to, you know, the word case has a huge number of meanings. And for us to understand and trade information about cases, don't we have to have some understanding of what that word means? So we have that issue of how do we create something resembling standards that allow us to talk to each other in a common language. The other dimension that's important is that we have a cultural proclivity in this country to always do the right thing rather than always figuring out what are the right things to do. We want to do things right, but we don't always choose what the right things are, and we follow whatever the objectives are of the organization that we are a part of. In effect, we are a stovepiped country. It starts with Congress. You know, right now, today, there are 50 separate committees in Congress that think they have oversight over the Department of Health and Human Services. And, you know, each one believes that they're the only one that has that jurisdiction, and they don't collaborate in any shape or form. So the 26 separate divisions in the Department of Health and Human Services operate autonomously in many ways and have their own committee to respond to and don't respond to any others. The whole system that we operate in has this stovepiped character, and When we talk about removing the boundaries between all these domains, we have the challenge of dealing with that legacy of stovepipedness, if you want to call it that we all live through. So we have to pay attention to those dimensions. So one way to approach this idea of NIC is to look at the success stories within certain domains that have been capable of bringing people together and forming a community of interest that have shown some success in the ability to actually share information that leads to stronger collaboration, which is really what we're about with this national initiative. So we thought today, our theory of change anyway, for starting this discussion this morning, is to look at some successful projects within the domains that we're focused on, and then explore how those successful projects, first of all, became successful, and secondly, how they can be scaled. Because what this initiative is all about, in my mind, is scalability. How do we scale from individual successful projects or efforts to collaborate and share information to nationwide information sharing and collaboration to make meaningful change in the wellness of our communities. We also have to understand that there is a need to come up with some kind of common interest across these domains that links them together into a community of interest. That's really one of the key success factors in any collaboration, is coming up with a common driver that says that people can believe in and be committed to. And I submit to you that if we think more broadly about the notion of the wellness of our neighborhoods, then we can incorporate the functions of public safety, public health, and education, and all the other domains that we're talking about. So today, what we're going to start with is trying to look at several success stories at the national level, at the state level, at the local level, and explore and have a dialogue with you about how can these efforts that have succeeded become more scalable and lead us towards a national interoperability collaborative. This is not just wishful thinking. These are projects that have actually done it. So how do we take them apart and put them back together in a way to scale this activity? So I'm very pleased to introduce to you the panelists. I'm not going to give their full biographic sketch. It's in your handouts. We have Tim Carney, Dr. Tim Carney, Senior Director of Data Analytics and Public Health Informatics from the Association of State and Territorial Health Officials. And Tim's going to talk to you about what that association has been doing at a statewide level, what has made it successful, and how it can be applied to these other domains that we're looking at. Dan Chavez is the Executive Director of the San Diego Health Connect project, which is one of the most successful HIEs in the country, and Dan has really gone through the complete history of starting with very little interoperability to build a capability in San Diego that's very successful. Marianne Dewan, Dr. Dewan is now the Superintendent of Schools in Santa Clara County, and we'll talk about how that all the districts in Santa Clara County have come together. And finally, Marianne Yeager is going to talk to you about the Sequoia project. Marianne is the CEO of that project, a highly successful health IT collaboration that we think has a lot of potential for scalability. So with these models, we're then going to ask you to talk about how do you see the capability for scaling these activities into this national collaborative. Okay? So let's start right down the row with Dr. Carney and move right forward. Tim?
Good morning, everybody, and thank you so much, Paul, for that overview and charge. It's a very serious mandate and a challenging charge that he set forth. My role at ASTHO is to sort of serve the directors of public health, one of which you had the opportunity to listen to yesterday, Karen Smith. I'm honored to have her in the audience because she's not only directing and leading California, but serves on the ASTHO board, so I better be very careful as to what I say. But I think Dan's questions earlier this morning about what were some of the takeaways from yesterday got me to thinking about what am I going to talk about today. And I know today we are not, at least this panel, is not supposed to be slide heavy, so I have very few slides. We're supposed to make this a conversation, so we want to hear from you as well. But takeaways that from our perspective, scalability, sustainability, thinking about how we take the best lessons learned that you provide us with and duplicating that across multiple states, thinking about what national metrics are. In other words, when we ask, where should the country be 3, 5, 10 years from now on interoperability, that's the kind of thing we need to define those metrics and then begin to measure that progress. Thinking about how interoperability is more of a process and not an event. And also thinking about the drivers of change. You know, what are the artifacts that actually help to trigger change in a given state at the scale that we see here today. So it's impressive, and I thank you for inviting me to participate. And I think I took myself off of, no I didn't. There we go. Okay, thank you. I am informatically challenged, so forgive me on that one. ASTHO serves all states and territories. We have the pleasure of serving, as I mentioned, the leaders in each of the states and territories, and we treat them equally. Regardless of capacity, regardless of resources, it is a community that drives national public health outcomes, state by state, and we're privileged to serve that community. We serve in partnership with many different affiliates. One of the core partners that I thought would be here, NACCHO, is our sister organization that functions at the city and county level while we function largely at the state level. And we typically engage in all of our projects jointly. But when we need to reach a specific cohort of stakeholders, we normally work through one or more of these groups. ASTHO is a large organization at many different groups, but where the informatics team sits, our charge is typically driven, one, to make that state health official, we view that person as the chief health strategist, thinking about how that person can be informed and empowered to move your state to wherever he or she needs to go in the course of the future. We do that largely through 3 clinical domains, or public health domains, I should say, excuse me. We have the Center for Population Health Strategies, and within that center we have the Clinical to Communities Connections, which tries to build bridges between public health and other healthcare domains. We have the Data Analytics and Public Health Informatics team. I'll talk more about that. And we have a Health Equity and Social Determinants of Health team, which is building bridges to examine how we can move the needle on minority health outcomes. The Surgeon General at our previous annual conference challenged us to think broadly and unconventionally. That means creating partnerships well outside of the public health domain. And our informatics team is reaching into each one of these domains, thinking of them as data hubs or data portals within which we can inform the decision-making needs of the chief health strategist. While that chief health strategist deals largely with governmental public health and the public health systems, in this world, the information economy is not limited anymore to any specific domain. We live in a complex, adaptive public health system, and in achieving the population health outcomes that we want, we have to have arms that reach into all of these domains, and ASTHO is making inroads into that. We also do a lot of our work through our network of informatics directors. As I mentioned, that there is a network of state health officials, but I operate day to day with the informatics directors, and I'm proud of the work that they do in shaping the information ecosystems that they manage. Jim Green, I've not met personally, but I understand is in the audience. He's your state representative here in California. But we, as you can see, we have representation across the country. Those states in white will be changing blue pretty soon. And one effort that I can point to as an example of how ASTHO actually engages states is the Digital Bridge effort. It's an effort that is looking at building bridges between public health data and clinical data across right now 7 sites, 7 different state and/or local jurisdictions, 5 states and 2 local jurisdictions. And at this very moment, Paul talked about the idea of creating learning opportunities. One of ASTHO's core jobs is to create learning and share best practices. We have a learning collaborative of 4 states going on at this very moment that I'm supposed to be facilitating, but was excused because of this event. We view this event so very much important that we have North Dakota, Illinois, Tennessee, and CNMI, one of the territories in the Pacific, talking about how they can engage this electronic case reporting effort and become ready to do what they're doing. So we would do something very similar for interoperability. We also conduct site visits. We develop guidelines and implementation and toolkits, and we're excited to be a part of the Digital Bridge effort. I should mention that this is an effort that's funded largely through Robert Wood Johnson and the De Beaumont Foundation. And they're doing good work. There are some challenges. There are some people in the audience today that can speak to some of those challenges, but the idea is to move on the vision. We start with the vision of the Chief Health Officer, down to the Informatics Director, down to the level where people are on the ground working to build change. And we also do that by largely informing governance. ASTHO supports the governance infrastructure. We build toolkits, templates. We support the work groups of the ECR. I sit on the ECR evaluation team, as well as the legal team and the ECR communications team. And my chief, Marianne Cooney, sits on the strategy and implementation work group, as well as the governance. But you could see here this infrastructure that was put in place, largely doing a lot of what I've heard this week, or this yesterday, and that is building models, defining change, defining vision, and moving forward. This is just an example of the data flow model, conceptual design of what Digital Bridge is trying to achieve. As you can see, it's moving across multiple domains, and we'd like to see something like that come out of this meeting. In other words, thinking about the flow of interoperability, the stewards of interoperability, the connective points, and how we can then share that or scale that up across all states. So with that, I'll pause and turn it over to Paul.
Thank you. So, Tim, what are the 3 critical success factors that you can talk about that have led to ASTHO's success in building your involvement in the Digital Bridge?
I thought I was going to have time to sit down and think about those questions. I would say first, we are operating in an environment that is funding challenged. The reality that the funds for informatics and the need for informatics, they don't correlate. And so we have to do innovative things. We have to develop innovative partnerships, think of ways to link our data in innovative ways that can supplement the lack of funds. So ASTHO has been successful in doing that. I would say, you asked for 3, right? The other 2 things, I would say one is that we follow the leadership of our health directors. In other words, we have our fingers on the pulse of what they need and what they want. And so any national initiative such as the Stewards of Change and the NIC, puts ASTHO and our sister organization, NACCHO, in a prime position to be at the forefront of helping to drive change. And then the third thing, I think we have a massive infrastructure around developing tools and guides. I think we do that for a living, and I think, I imagine out of this effort will come a dynamic toolkit for interoperability for the country.
Great, thank you.
Very welcome.
Dan Chavez.
Good morning. It's great to be here this morning, and want to talk a little bit about what we're doing in San Diego. You heard from my colleague and friend and collaborator, Carrie Hoff, yesterday. So I'll do my very best not to repeat what she said and talk about the 6 domains. I got the pre-reading material from Daniel. That's only 6? This should be easy. I can associate 6 domains to what we're doing in San Diego. And then I looked deeper and harder, and this is going to be difficult. So let me talk about the 6 domains very quickly as to what we're doing with the Health Information Exchange in San Diego. And as you might expect, given that I run a Health Information Exchange, I think that is a solution for interoperability and healthcare reform and all the wonderful things that we're doing. And now, Health Information Exchange is different in every part of the country, in every different market. So let's start with what we haven't addressed quite yet, and that's public education. We're about to, because we finally have a kernel of value that we're going to offer to our schools, and that's a bidirectional interface to our immunization registry. We have a local immunization registry. And it's our hope and our intent to eradicate that little yellow card with immunizations. And then Marcy agreed over a glass of wine last night that she's going to help me do the rest. It was one glass between us. I'm not sure how many she had before me. Let's move over to the right and talk about HIT, a very complex subject. It's not just electronic health records. That's not just HIT, it's a whole variety of systems, many of them old and legacy, that have got to be connected and made interoperable with the rest of the network. And then let's move up a little bit. That's been our focus, and it's largely hospital-driven, and that's both good and bad. You'll see things out of Washington that says that we're not doing a great job with the ambulatory environment and the white space. And we've got to do a much better job of bringing in post-acute care and those healthcare providers that are not near our major populated areas in the ambulatory space and in the white space, and get them involved with health information exchange. And we're focused on that as we go forward. But we had to start with the larger institutions. Why? Not because they had the money, but because they had the data. And you have to build a foundation with that data. And I thought Jess did a wonderful job summarizing last night very succinctly in patient identification, consent, and semantic interoperability. That really sums up what we do in health information exchange. Public health, fortunately, largely because of meaningful use. It was funded by meaningful use. We did a really good job in San Diego of tying our public health entities together with the HIE, and we've seen this now tested and proven. As you may have read, in 2017 we had a horrible Hep A outbreak in San Diego. It was very challenging for us as a community, especially for our tourist industry, but we came together as a community with the HIE in the center of that in terms of an interoperability scheme that really, really worked for us, and that was on twofold. We had 600 people impacted with the disease. 95% of those cases were reported real-time automatically through the HIE. Why 95%? Well, I don't have 2 hospitals participating, unfortunately, and the blood banks aren't going through the HIE, and that was the 5% that we were missing. As a result of that as well, we did 120,000 vaccinations in a 6-month time frame. 20% of those were for healthcare workers, public servants, first responders, et cetera, but we had to track all that through the HIE. And 120,000 vaccinations, and now we're going through the second round of that, is not a simple challenge. So public health did a very good job integrating public health. And in fact, if you read some San Diego papers, I have this different part of my presentation, places like Los Angeles and San Francisco said, don't go to San Diego. They've got a horrible Hep A outbreak. They're struggling with flu. And our response was, no, I mean, all that is true, but we have better information, and we get it real time. And that's courtesy of our health information exchange. So you can't always believe what you read in the newspapers. EMS, again, we started as a beacon program in 2010 at the UCSD School of Emergency Medicine. We've been tying EMS closely to the HIE. We received an ONC California EMSA grant to do even tighter integration. And we are rolling that out as we speak. Our ambulances are connected to the HIE real time, and we can do a proper identification in the ambulance, download a problem list, an encounter list, an allergy list, and a med list to the ambulance real time, and are achieving phenomenal results. One of our results last summer was that we had a heart attack patient in the ambulance, and from arrival to stent in the chest, 16 minutes. The national average is 45 to 60. Average ambulance ride is 20 to 25 minutes. So all that is automated and works real time with our EMS agencies. Public safety, again, very lucky, very blessed, not only live in San Diego, but work in such a great collaborative community. The sheriff of the county of San Diego demanded to be on my board of directors. Demanded to be on my board of directors. And it wasn't for criminal justice. It's because he's responsible for the jail. And the jail has health care in it with special circumstances both in, during, and out of incarceration. And so our sheriff had the foresight to say, I need to be part of this, I need to be involved in it, and I need to be on this board of directors. One of the messages that was said earlier in the opening comments about relationships, if you want to have successful interoperability, involve those who are not involved on your governance. Invite them to the table. Now, I was fortunate. I didn't have to invite the sheriff. He invited himself. I wasn't going to say, no, he's got a gun. But nevertheless, we have the fire chief of the city of San Diego on our board of directors. If they're not part, and they should be part, invite them to governance. If they're not technical, if they don't understand interoperability, they can't spell population health, invite them to the table. Because it works, and it's a process, and it's got to start, and they need to be part of governance. And I left the biggest for last. I thought maybe, Daniel, I'd make these ellipses with size. But human and social services, as it relates to data, will be orders of magnitude larger than any other ellipse on the chart. And it's complex, and there's many more organizations to deal with in human and social services than there are other places. And it's going to be quite the challenge. And I've got great partners like Harry Hoff and Bill York, from 211 San Diego, who spoke earlier, and we're working hard to make this happen. But it is public, it's not for profit, it's private, some of it's for profit. It's gonna be a challenge. So what does that look like? I borrowed this from my friend Steven Singer from the Camden Coalition, but I really think this is the goal. This is a retrospective analysis. Spend some time on this when you get a chance. But you'll notice down the left margin, addiction, mental health, accidents, fights, social correlates, housing type, police encounter types, public nuisance, theft related. But what we need to drive to is a comprehensive 360-degree view of our populace and have that information readily at our fingertips. Now, this is a retrospective analysis. You see it goes 2010 to 2014. But ideally, we want this at our fingertips real time at any given point in time. And I think this is an amazing presentation of a 360-degree view of an individual. We're not there yet, but I really do believe this is the goal. Similarly, we did this with one of our Hep A cases. Here's a homeless individual, male, age 30, 10 ED visits, 1 hospitalization, 1 Hep A vaccination with a problem with alcohol. But we did this as a retrospective analysis of some of our Hep A patients. And we're building, and we hope to do these things more on the fly for an outbreak like this, a patient registry that gives us information like this readily at our fingertips. And I really do think this is our goal. The only way we make this happen is through interoperability. So I'll talk about interoperability, and there are a variety of interoperability schemes. Marianne's going to talk about some of those. Desperately need what Marianne does as part of San Diego and San Diego Health Connect, because it gives us tremendous connectivity and connections to other electronic health records. But this was a HIMSS study that was done last year that says this is all you have to choose from in terms of interoperability. You might note I've put the San Diego Health Connect logo in 5 of those boxes. We utilize 5 to make San Diego Health Connect work. There is no one scheme. It is a variety of schemas. It is not a function of or, but a function of and every market's different. Even every market in the great state of California has a different mix of these schemas to make it work. And so you need to get yourself educated and smart on this set of schema and what works best for you and your market. And yet, based on that HIMSS study, some things stood out. It is a multi-pronged approach. We're not there yet with standards. It's still very provider-centric. I know we want to get to patient-centric, but the base is still very provider-centric. As Jess mentioned, we need semantic interoperability. This is a real barrier to utilization of that information. Quality is all over the board. We need to work on quality much more as an industry. And as Jess mentioned, there's no common solution on patient matching. So having said that, again, take those 6 domains and how do you best weave them together? You focus on patient identification. You worry about data quality from the get-go. You worry about data provenance. This is important, really important, often forgotten. That's the metadata that has to do with this exchange as to where it came from, who made the changes, and how it was changed through the exchange. Now, you need to tie public health to primary care. You need to have a good, proper presentation that speaks to how do I use the information once I get it, but you got to be really cognizant of who's using the information. You need that closed loop referral system, that feedback loop, and real-time notifications, alerts are where they need to be. So as we look to San Diego, we looked at 211 San Diego, what Carrie talked about with ConnectWell San Diego, we have 3 infrastructures. We've got to weave them together. They were stood up on their own, and we have programs that require utilization of all 3. So we stood up 3 in San Diego. We're putting them together slowly but surely. If you're just starting, go with 1 infrastructure. Don't start with 3. It's much harder to connect. It's like building a bridge from 3 different places. Start with 1 infrastructure. Those things are much easier to do with 1 than with 3. And then finally, I think this is where we're going, to population health. This is courtesy of Dr. Doug Fridsma of EMEA. But it puts the patient at the start. It worries about the population, it worries about the public. We've got to get here. So thanks very much.
Thank you, Dan. There's been a lot written about the variable effectiveness of HIEs throughout the country, and as you've admitted to me privately, there are certain HIEs that are successful, as yours is, but there are others that are just really not cutting it. So how would you scale what you've done to bring the other HIEs to that same level of effectiveness?
So I think we have to really focus on what the challenges are with interoperability in any given market. Again, they rely, as again just said, patient identification, consent, and driving the quality of data to a unified presentation of information. So I think there's got to be an assessment with those HIEs that may be struggling, and really focus on those three areas to get the ship right. Thanks.
Dr. Dewan?
There we go. Good morning, everyone. It's really a pleasure to be here and to have the opportunity to talk about data with a friendly audience. It's not always the case in my world that it is a friendly conversation. There's a lot of concern in the field. I am from the Silicon Valley. Santa Clara County is home to Facebook and Apple and all those companies that you all know really well in the tech world. And there's a lot of concern that is frequently brought to bear around student privacy, student data protections, how we're using data to drive social policy and maybe driving it in the wrong way. And so I'm frequently a part of conversations where the conversations are much more difficult to have than the ones that we're having here together. Just a few other things about Silicon Valley. We have about 500,000 students. I'm going to focus my remarks today on public education primarily. And I want to say that I'm really proud to be associated with the Silicon Valley Regional Data Trust Initiative. The project has been a labor of love for me for the past 5 years. And I'm really proud that our office has held a significant leadership role in helping to make it a success. However, today I'm going to talk primarily about two high-profile education-focused data collaboratives that we have in our office. Since about 2007, technology has increased so rapidly that much more is possible than ever before. There certainly is more that we can do with technology. However, I find that my role as a leader is to try to answer the question, just because we can, should we? I think leaders must help answer that question, and we should think about it from the ethical perspective and the various levels of ethics that are associated with the work, including the day-to-day practical, what happens on the ground floor for the practitioners who are interacting with our clients, our students, our families in the community. The first collaborative that I'm going to speak about is our Datazone initiative. Our data trust colleagues mentioned it yesterday as our education data repository. It is an educational data warehouse. It was designed to build collaboration and to position schools and agencies for appropriate and ethical data sharing. If you know anything about public education, you know that every school district and every school has a myriad of data sets and data information systems. They have a student information system, they have student testing, local and state, they have health records, HR, business, et cetera. And all of that information is useful and beneficial in making decisions, but it all lives in a variety of different places. In my county, I have 31 school districts of varying sizes. And if you want to do anything with county level, regional, or state work, we need to find a way to pull that data together into one place in order for it to be useful. And also just to have the efficiency that would be necessary. It's literally impossible for our county agencies to develop relationships with each and every one of the school districts and then extract data in a way that is comprehensible and useful. I can't understate the value of Datazone for the schools and the school districts themselves, and also for all of us who depend upon education information for case management, for program evaluation, and collaboration. One of the things I think that helped make our initiative successful is that initial participation was voluntary, and it still is voluntary for our districts. There's no mandate. We don't force participation. Districts immediately, however, see the value in bringing in the data from their disparate systems within their own district. Trust is an essential component to our work. We use data to help support our schools. In many cases, it's the first time that our schools are able to see their own data projected back to them in any meaningful way. When we talk about personal trust or institutional trust, I think it starts with our personal values, the personal why. Why do I care about data sharing, and why do I care about data security and data privacy? I care about those things because personal experiences, own children in my family with disability, siblings with post-traumatic stress disorder, situations that make it very clear that systems have to work together and we have to have useful information. But as we're building this institutional trust, we also have to think about the systemic why. Why does the system want the information, and what are they going to do with it? So as we were building our Datazone vision, some of the things we thought about had to do with the cost associated. Public education in California is underfunded. We are about 46th in the nation in per pupil expenditures. It is quite difficult for districts to make investments in efforts such as this. So by the county office taking the lead, we're able to provide really low-cost data warehousing, giving them dashboards back for decision-making, and promoting action, a bias towards action to support them with just-in-time data. The power of that current data is really critical because most of the data in education is latent. By the time we're looking at it, it's a year or longer post-action. Another way that we were able to generate interest and support in our Datazone initiative was that the state changed our accountability system to have a focus on county offices helping to coordinate services for foster youth. That was a great entree for us to have conversations with districts about pulling in data. And I showed this dashboard. This is just to give you a quick peek at what Datazone looks like when you go in. There are 90 dashboards, all kinds of metrics, lots of tools to help cohort students and to do a variety of things with the information. We're always happy to do a full demo anytime you're interested in seeing it. The way Datazone works is we take information from various data sources, we pull that into the data warehouse, we apply some analytic and reporting tools to it, and then it gives us information that we can use for a variety of reasons. It's those variety of reasons that are the call to action for our districts, because they're doing that work anyway, but they're doing it in a very inefficient and ineffective, time-consuming process, and Datazone helps expedite that for them. Obviously, for our Datazone initiative being a focus on public education, instruction, and what happens in the classroom is critically important. So giving just-in-time real information as well as longitudinal information can really help drive an instructionally coherent educational program for classrooms, for schools, and for districts. Another initiative that is associated with Datazone is our Foster Vision tool. This is the module within Datazone where we're able to pull information from social services and juvenile probation, and we share information on active foster youth cases. This information also helps us be very responsive to court judges who care deeply about having accurate current information as they're making critical and in some cases life-changing decisions for the young people under their care. So our Foster Vision application is provided to our districts at no cost. I heard somebody say yesterday, free is for me, and I think that's been really true for our districts. The way for them to get invested in Datazone was through Foster Vision, and it has been a service that we've provided at no cost to our districts. This is what the Foster Vision dashboard looks like. And then just to close up, I want to talk about a few things about our purposes, improving outcomes. Within Datazone, we have early warning systems. We have some tools to help monitor chronic absenteeism, and we're building out some tools on social and emotional well-being. Really critical and high-level information in this time where campus safety and mental health are of primary and top of mind for many of us in the world. In our efforts and partnerships with the county, we have some partnerships to provide behavioral and mental health services on school campuses through our School Link Services Initiative. And we're really proud that the county has trusted us in our Datazone project as a primary source of data sharing to support the School Link Services Initiative. And we're also building out with our partners at First Five a more comprehensive early learning set of dashboards that will bring a longitudinal data set from 0 to 5 as youngsters transition into K-12, and then sustaining that throughout their K-12 career. I'm sure you can imagine the benefit of having that data set. And then lastly, and recently, our County Board of Supervisors have been working with our office on a joint foster youth task force. And one of the primary recommendations from the task force is that the county strengthen their partnership with our County Office of Education to expand Foster Vision and Datazone and participation for all of our school districts in the county. This is very scalable. We already are working at the regional level with Datazone, as you heard through the data trust conversation, and we have the tools and capacity to expand throughout the state of California and beyond. And in closing, I just want to say that we all have a duty to support the ethical use of data and to understand the why behind the questions that are being asked and how we use the data. Having the tools is really important, but being really clear about our role as safeguard of our students, of our communities, is really an essential component of leadership. Thank you.
Thank you. It's very interesting to note your ability to share information with the social services and that you've begun to address the other domains that we're approaching. I'm wondering how you went about establishing trust between the people outside of the school system that you've incorporated as well with the school system itself. How did that work?
As was mentioned yesterday, this was a case where relationships really played into our favor. Having really strong, credible relationships, keeping our word, starting slow and small, and proving that we meant what we said, I think was really essential. And then the shared mission and vision. Like one of the things we say is, and that I say in all of my talks is, we don't want to accept the things we cannot change. But really we want to change the things that we cannot, that we can no longer accept. And I think that relationship building around those shared whys and that shared vision really were the foundation of building trust. I also think that our commitment to privacy and to the ethical use of the data has been really essential, because there have been a lot of cases in our county where data was used to rank, blame, and shame. And we have made a commitment that we will not allow our tools to be used for those purposes.
Thank you. Marianne.
Good morning. Marianne Yeager, CEO of the Sequoia project. Thank you, Daniel and Paul, for inviting me to share a little bit about our work at Sequoia and how it might play a role with the collaborative effort I think that the NIC has under consideration here. So a little bit about Sequoia. So we are a nonprofit with a public mission. So we are solely focused and chartered on focusing on solving interoperability. So we've talked about interoperability a lot today, and when we think about interoperability, it's really within particular domains. So I'll talk about those. It's really principally been around health information technology, and I think as Dan had said, it's not just EHRs, although electronic health record systems are pretty foundational in enabling those systems to interoperate with other systems, but also IJIS systems and really any other health IT technology. So our work today is principally used to support treatment and care coordination. There are some human services, I suppose you would say, in supporting the Social Security Administration and providing a digital way for them to access a copy of an individual claimant's medical records to substantiate that they're disabled and therefore eligible for disability. Our efforts also support quality measures reporting and then alternative payment models. We've more recently moved to support a public safety use case and supporting a patient unified lookup service for emergencies. This service is actually was developed by funding from HHS and actually piloted and used in California in support of the wildfires. And so our work was really used to connect those disaster healthcare volunteers to existing data sharing networks so that they could access an individual's records when they're displaced by disasters and seeking care in alternative care facilities. We've been looking at other potential uses for our work because we do have a foundation. I'll talk about that. So emergency medical services actually would fall under what we consider pretty mainstream treatment use case. We've had conversations with different groups around the country and how it could be used to support 211 programs, as well as supporting other public health use cases. So there are a lot of opportunities to overlay other uses of these networks and support, particularly in areas where there might not be a robust HIE, like in San Diego. Dan Chavez, you're so lucky, and the people in San Diego are very lucky to have such a robust HIE, but that's not the case. And so a lot of times we focus our energies on trying to fill gaps and to enable. So I wanted to share first what we have accomplished and then really focus on the lessons learned of how in the spirit of sharing collaboration. So our work really started, and the company was first formed to support an initiative which was started by the Department of Health and Human Services back in 2008. And I don't know if any of you recall this. I know Will Ross and others here certainly do. The Nationwide Health Information Network, and that was really to support the ability to have a standardized way to share information across various jurisdictions, geographies, health IT systems, and clinical settings across government and private sector. And we really, as the government incubated that, and it really grew beyond a proof of concept, real data was being shared. The company, Sequoia, was formed as a C3 back in 2012 to be the steward of this activity going forward. So at that time in 2012, if you think about it, this activity started back in 2009 when there was a very low adoption rate of electronic health record systems. So most of the data being shared was, information shared was paper. And when we became the stewards of it, it grew to now cover all 50 states. This is the principal way that the Department of Defense and the VA share data and access information with the private sector. So this supports 9.4 million TRICARE beneficiaries, so active duty military retirees and their families, more than 9 million veterans who've served our country, and the more than 10 million people who qualify for Social Security disability benefits every year. It also covers the vast majority of U.S. hospitals, a very large number of medical groups, 59 regional and statewide HIEs, and as you can see, every CVS Minute Clinic, every Walgreens. And so these groups are all interconnected under a common legal agreement with a common set of policies so they can share information without having direct relationships with each other. So even though the eHealth Exchange is a pretty big data sharing network, there are multiple. So some of these networks are regional and statewide, as we mentioned, and then the vendors, the EHR vendors themselves have networks. So and then there are a role of service providers to really be able to search and find patient records. So Care Equality was formed to develop an interoperability framework to interconnect networks, much like in the cellular industry did to interconnect the different Verizon and Sprint networks. And so today this is just a sampling, there are many others, Epic as well, of course, a pretty important network and implementer that's participating, but it represents about 90% of all electronic health record systems will interconnect through carry quality. So some of them are doing it through their own networks, some of them are starting that providers are connected through the HIE or the eHealth Exchange, but the interoperability framework really for the country that represents the lion's share of clinical data sharing is occurring under carry quality. And so today, this effort started and started being shared in July 1st, 2017. And now today, you can see the benefit in the, of connecting networks. You get to that instant scale much more rapidly. And while it took, 7 years to build the eHealth Exchange to that scale, carry quality was in just, 1 short year. So now today, there are more than 2 million CCDs exchanged monthly. So these activities are massive, large-scale efforts. We're starting to see more density in the connectivity. So the first number of years was really laying the groundwork, done a really good job of getting the health systems and large organizations connected, and now it's a matter of focusing on ambulatory. So what do we learn in this activity? Well, first of all, collaboration was at the forefront of everything that led to this work. It started with a common mission. I think a lot of the other speakers have noted that you have to have that shared goal. But what was unique about this, particularly with the leadership of HHS, was there was really executive level leadership, as in the Secretary of Health and Human Services, Mike Leavitt, was the one who said, this is what we want and need. And he was the one who wanted to basically support the federal government in incubating this activity. Rather than the government really creating it themselves, they brought together a cooperative, so 12 federal agencies, some of which I just mentioned, but also SAMHSA and other groups, ASPR and among others, and as well as 18 private sector organizations, and together they formed a cooperative, and they were given a very specific goal. They were given a goal. They had to come up with an operational instance and begin sharing information around 7 specific use cases, and they were given less than a year to do it. And they had to figure out how the legal terms, they had to figure out the technical specifications and requirements, and it was all upward visibility, and to present it to the Secretary of Health and Human Services in a live demonstration. So I would say it was sort of insane having been part of that process, because it was a virtually impossible goal. But what it did was it really forced the issue to get to something that was tangible and implementable. And so by having that narrow focus on deciding what to implement first was really the catalyst to change. There are many, many different things. You all have discussed many different ways to move data in support of your many different programs. But if I could offer one word of advice, I would say pick 1 or 2 that you can be successful and execute them. It's not going to be perfect. They make incremental progress, goodness knows, and then really have those specific commitments and deliverables and focus it around implementation. The other lesson learned, and this is really almost my next last slide here, was there was skin in the game in that there was accountability for noncompliance. So every partner who participated in that activity had to sign the same set of terms and legal agreements, whether they were the DoD or a regional HIE, they all were bound by the exact same expectations and obligations. And there was oversight by a governing committee, and there was a clear allocation of risk among the participants. And so it was really that having that common underpinning that it wasn't, it was voluntary in whether or not you wanted to participate, but there were implications if you were not compliant. And so having those rules of the road codified in a way where there was accountability was important. Those terms of that legal agreement endure today. So 9 years later, they still are the primary tenets of what worked. So what I would say is, governance is going to be really imperative. It should be inclusive but operationally nimble. And it would be, what we found is that stakeholders were willing to commit and actually deliver when it was tied to real-world implementation, not a proof of concept, not necessarily a pilot, but something that they would use day to day in their activities. By having a national level approach or a shared approach, there are significant savings. We actually did an ROI. If each of those 4 federal agencies had created their own separate network, it would have been about a $240 million investment. By having shared savings and operating it through a public utility, like an organization like Sequoia, we drive the cost down to a commodity level where it's virtually free. And so that's really our goal. And I think there's a huge opportunity for you all to really operate under a shared utility and come up with what are the common denominator things that have to work universally, even if it's implemented locally, what are the things that are universal, and really focus on those. And then finally, by having a network that supports multiple use cases and approaches, you don't have to have a separate network for all these different purposes. You have one common underpinning, one agreement and supports many different uses, many different technologies, and it can be repurposed. And there's far more cost effective to support a common data sharing activity that can support many uses than to have a specialized network for every area of the 6 domains. So I would really encourage you all to focus on that. So with that, I will turn it over to Paul.
Well, I hope you can see why we've asked these people to speak to you this morning and to talk about some examples of how collaboration has really turned into reality. And what we're really about now, and with our remaining time, is to ask you to comment on what you've heard and also to ask questions. But think about how this is, how what these folks have done can be scaled to the National Interoperability Collaborative. So the floor is yours. Yes, sir.
Marianne, could you talk a little bit about TEFCA and your perspective on Sequoia's role in it, and maybe Dan, if you have some thoughts too.
Repeat the question.
So what is
This-
No, it was green. Yeah. Are we on now? Okay. So what is TEFCA and what is the relative potential role of Sequoia and others? So the Trusted Exchange Framework and Common Agreement is a concept that was introduced in the 21st Century Cures legislation, where Congress felt that more needed to be done to interconnect networks. And so that at that time, the work that we've had with carrier quality was still in its early stages. Obviously, there's a lot more progress since then. So it requires that the Office of the National Coordinator either develop or support a trusted exchange framework and common agreement. So what that means, a common set of terms for data sharing between networks that would be codified into a common legal agreement. It could be voluntarily adopted and used by networks, health information networks who are qualified. So if you're a health information network and you want to be deemed a qualified health information network, then you would have to sign this agreement and subject yourself to all these terms. So the ONC has actually published a draft terms for public comment, and they're processing those. One important role that the ONC has contemplated, this wasn't spelled out in Cures, but it was a concept ONC came up with, was that there should be a recognized coordinating entity, which is a private sector body who would operationalize the common agreement. So what they're saying, what ONC is saying, is that they want to come up with the set of terms, but they want to work with a private sector organization that can operationalize the agreement and oversee and facilitate governance of the QHINs. So. What is Sequoia's role? So you can imagine that the description I just shared of the RCE and the TEFCA sounds a lot like our work. I mean, and it's obviously we have a vested interest in supporting and continuing interoperability in the public interest. So for us, I mean, we're going to look at it. We don't know what ONC's expectations are around the RCE. We don't know how much influence they would impose. Right now, our work is voluntary. It's consensus-driven. It's facilitated by the broadest stakeholders imaginable. I mean, I glossed over the whole carry quality process, but there's a 27-member advisory council with a whole representation from the whole litany of industry that shapes that work. So, I mean, we're just going to look at there's a funding opportunity announcement coming up. We're going to look at it. We think that we have a lot of strengths and that we could play a role there potentially, but until that comes out, it's hard to say. And then we also need to understand our litmus test is this in the public interest? Is this going to move the needle forward? Because if it isn't, then I don't know, we should be just blindly moving forward with that as an approach. And I think there's a lot of skepticism right now about what's right. So, Dan?
So, great overview, Marianne. On balance, I think we're generally supportive of TEFCA. It tries to build upon the existing work that's been done in health information exchange, the Sequoia project, eHealth exchange, care quality, other interoperability schemes. Its intent is very well placed. It's got to draw in that white space in the ambulatory environments better, faster, cheaper. And it's a mechanism to try and do that. Is it the best mechanism? You know, it's the regional national trade-off is difficult. It's got NIC and TEFCA has to achieve that balance. And we've got to do a better job, in my humble opinion, of propagating what's been successful in different regions and getting that much more national in scale. I think the Sequoia project is a good way to do that. So again, I think it's a good approach on balance. It needs to be tweaked a little bit. It needs to find a little bit more balance. It needs to take more advantage of what's worked and have that propagated across the states.
Yes, ma'am.
Thank you. First of all, thank you. That was an awesome set of presentations. Secondly, may I give you a real-world problem? And I'd like to hear from each one of you. Supposing in America we wanted every baby born to be on target developmentally at age 3. Every single one. That's not the case today. In the city that I'll talk about in a little bit, 3/4 of the children who turn 3 are behind across a variety of domains. You are part of the answer. So how can you help us?
Well, there are national networks available at your disposal to access and get access to information on that child's records from the point they're first born. And I mean, I would say you could overlay all the use cases that you all talked about, and if there is a touch point with getting access to clinical information, that's the touch point to the work that we and others support.
I think I would approach it from a universal access and systemic views, thinking that our current systems are not aligned to achieve that outcome that you just described. And in order for us to be aligned that way, we need to have some universal applicability and universal processes in place, such as family engagement, parent training, communication and agreement about what does being on track at age 3 mean? What are the indicators of health, well-being, brain development, et cetera? From a why perspective and policy perspective, I think it is the right question. We know that 90% of a child's brain develops by age 3, and we know that the investment in those first 3 years is an investment that pays off.
I hate to answer a question with a question, but what information do you need to ensure to make this happen? And then I think you would task us to go get that information for you, have it available to who needs to have it available to, and present it in the manner that you need to have it presented in.
I think it's very similar to what Dan said in that ASTHO was actually presented with this challenge through the former president's challenge from Barbara Fitzgerald. They're working on that problem now. From an informatics standpoint, I typically stay in my lane. And so I'm asking very specific questions about what the surveillance capabilities are now to monitor and track progress, to detect clinical outcomes and aggregate those upstream to inform county and state leadership. I think that problem use case has not been flushed out because they're still dealing with defining the problem and looking for opportunities where people like me can help serve that use case. But it's something we're on. It's happening right now at our organizations.
I think I would just add a consideration there that it can't be a focus on just the child, that the child is part of a family unit, a community, a neighborhood, a system, and any approach needs to deal with all of those components.
Thank you. I really appreciate that. All of your answers. They feel a little distant to me from individual children and families, which is where some of us are. We're going to talk a little bit about this particular problem, but I did want to thank you. I would like to just refer to the Virginia gentleman who was our governor for a minute. Where are you, Jim? He's here. I know he's here. Bill, I'm sorry, Bill. Well, good. If I had his name right, that would help, wouldn't it? So he stood up yesterday and said, basically cut the crap. There's some urgency here and I need answers. And I would say back, when we get a chance to talk some more today, that a baby is only 1 year once, and every day is a day that baby can't get back. So I'd like to ask for people to help us think about how we put urgency behind this using the incredible technological, that's not the problem, but how do we use that to push us to get to a spot we'd like to talk with you about later. So thank you for letting me do this to you.
Karen?
So, comment more than a question. And this last question actually brings it up. One of the, we have these, I agree, technology is less the problem. It used to be the problem. But now, we're not even, we're in a position where we have access to amazing amounts of data, interoperable data. And the questions that we want to ask are very complicated questions that have to do with many different societal determinants that ultimately impact health or some other outcome, economic, sustainability, et cetera. What we really lack is the science of evaluation. So you can ask the question, you can put an intervention into place, but if you don't appropriately evaluate that intervention, and particularly when we start talking about place-based interventions, we're going to go into a community and prove multiple societal determinants of health. You can't just look at return on investment to the healthcare system. That is a fantasy. And most people look at that because that looks like a way to pay for something, but that is not going to happen. We can have that whole other conversation. But really, the savings are to multiple sectors, and we don't have, there's not a cadre of people out there who know how to do this. I know because we've had money for the, to actually do those evaluations. And so I think that the more data, the more sectors, the more different kinds of information you can get from that, putting it into a framework that really provides you information, and particularly information about how effective you're being. I don't think we just want to look at the data. We want to be able to say, kids aren't doing well, let's try X. And so that's the next, for me, that's the next really big challenge, is how do we create that science of multi-sector evaluation? So, and if you know the answer, please, I would love to hear it.
One more question,
Well,
Marta?
I'm going to bring this over here. I hope that this afternoon we have a panel with a bunch of esteemed researchers. So for those of you who are going to be prepared, you'll be talking during that time, I think that's an important question that we're thinking about relative to how do we address those. What do we know also, right? What do we know already? And do we know enough? And can we mobilize that information? Or do we need to just continue to study it? As per Dr. Hazel's perspective, just do something already, right? I mean, are we in that position? And where do we need to go? Thank you, Bill. Right, it's both. Right, Bill made that very clear. It wasn't either or, he was suggesting yesterday. But there was a... There you go. Well, I didn't get it straight the first time. So.
Dan, I promised Marta to have one last question.
Yeah. I think we're going to let this go for just a couple more minutes
Okay.
if there's energy around it here. So.
Thank you, everyone. Amazing work. I hope I can accomplish a quarter of what you all have already accomplished. So, this question is for Dan. And Dan, you mentioned that there are 2 hospital systems that are not participating. I always figure you build it, they will come, right? And so, do you have marketing outreach efforts? If I were a patient in one of those hospitals, I would be very upset that I was not part of this information exchange. So. How do you, well, I'll just leave it there.
Sure, every year I go and I make my pitch and ask them to join. Unfortunately, they're the 2 for-profit hospitals in our community, and there may be a little association there with not-for-profit versus profit status. I think we've made the sales effort. They're moving to Epic, and so it's best if we allow that migration to occur first and get that complete and get their focused energy on making the transition to Epic and then bring them up on Epic. And I think that's going to happen here in short order, maybe not 2018, But I'm confident that we will have 100% of the hospitals and 100% of the FQHCs on board with the HIE at the end of 2019.
What's their primary rationale for not doing
They didn't believe in the concept. They honestly believed that it weakened their competitive position. I think we've proven that not to be the case, that membership in the Health Information Exchange actually made them more competitive and more profitable.
Okay, we're going to steal one more moment from,
Super.
because Uma's dying to say something.
Well, so I'm speaking from a county perspective. You all have shared governance, and particularly, Marianne, I reacted to your point, which was standard contracts, standard terms and conditions, very hard for county attorneys who are very risk averse. And so my question's really directed towards how do we engage them in a conversation about standard terms and conditions. Our county attorney always wants to change standard terms and conditions. It took us, I kid you not, over 24 months to engage in a contract with CRISP. We wanted to engage in a contract with CRISP because it was feeding and CRISP is our HIE at this state. We wanted to engage with them, but it was worse than trading your firstborn child. You know, painful, painful, painful. So I would love to hear some wisdom from all of you as you talk about that.
Well, that was part of the cooperative process of the governmental agencies. There was representation from state and federal, and it helped to have the Office for Civil Rights and CMS and SAMHSA and all these authorities, you know, present, and with the private sector organizations, and it was facilitated through a consensus process of here are the minimal terms we all agree to, and if somebody objected to it, they had to come up with terms that everyone could universally agree to. So that process took 6 months. Yes, less than 24 months, and at the end of it, everyone was expected to sign it. So the agreement went through a multi-agency clearance process, went all the way up to the HHS secretarial level, all the way up to the DoD top folks. So it was pretty well vetted, and I can tell you, in the past 8 years, that agreement has not changed.
Are you able, just to follow up, are you able to change and share the terms and conditions?
Yes, it's on a public website. All of our work, our specifications, our governance, everything is on our public website, and we're happy to. But I think that's going to bode really well for you all. I think it's a little harder if you're dealing with interagency agreements, or, you know, locally there might be things unique to you all, but the terms are really well established. And, you know, actually the agreement, I should correct myself, is undergoing an amendment right now. And we used a similar process, again, of consulting with the 4 federal agencies first, because while your county attorneys may be conservative, I can assure you that the DoD legal counsel, wow, they are really conservative.
In San Diego, we have common agreements as well, and it is fundamental, really, to success as having the standard agreements, and it starts with governance of the HIE. We have a monthly work group that deals with privacy, confidentiality, and our agreements. And so we usually have a long runway as it relates to changes, similar to the process that Marianne mentioned, because we're going through that with Marianne as we speak. And then we're very close with the Hospital Association. As a key factor and variable in our success, oftentimes what happens is our board of directors will pass something that I'll take to the Hospital Association board of directors and get their buy-in. And when the largest institutions buy in, the county, the hospitals, everybody else pretty much follows, because everybody else knows it's been very well vetted and exercised.
And I would say that our agreements already account for your use cases. You can piggyback.
They do. They
You
do.
can piggyback on the infrastructure that's been laid. You don't have to pay for this. And we already have the lion's share of provider organizations and HIEs and governmental agencies at a federal level, VA, right? And the EHR vendors.
And
why not?
Kaiser, and Kaiser.
Kaiser Permanente. I mean, the list goes on and on. It's really impressive. I mean, Sutter Health, and I mean.
Our contracts are modeled off of Marianne's, and we stay that way, and it flows down through the ecosystem.
But what you're really addressing, Uma, is exactly what we're going to talk about later today, about what are the contents that we should be putting up in the National Interoperability Collaborative. Yeah, we're not here to reinvent the wheel. We're here to take advantage of the work that's already been done and make those resources available to everybody in the country. I want to thank the panel for their contributions today.